Hello, I'm Andy Rosenkrantz, Editor-in-Chief of AJR, and I welcome you to our second AJR Forum. This event is being live streamed on multiple social media platforms, and the recording, along with a transcript, will later be published in an upcoming issue of the journal as a multimedia article. The topic for today's forum is quantitative ultrasound. Major advances in ultrasound technology in recent years have led to novel uses of ultrasound-derived measurements, including speed of sound, attenuation, and backscatter to characterize tissue quantitatively. These new ultrasound methods have been used to measure tissue stiffness, flow, fat, and other properties to evaluate diseases in various organs. These methods are entering the clinical arena, although remain dependent on optimal technique. Standardized protocols will therefore be needed for quantitative ultrasound results to be generalizable across the literature and across centers. These issues will form the basis for our forum today. With that, I'm delighted to introduce our host, Dr. David Fetzer, Associate Professor of Radiology and Medical Director of Ultrasound at UT Southwestern Medical Center. Dr. Fetzer, we thank you for being here and leading this event today.
Thanks, Dr. Rosenkrantz. I really appreciate this opportunity. I'm very excited to help moderate this group of esteemed lecturers, providing everyone on the forum today with some fantastic information on 4 broad topics. So from Dallas, I'd like to introduce our first speaker, Dr. Ivan Rosado-Mendez, PhD, Assistant Professor in the Department of Medical Physics and Radiology at University of Wisconsin-Madison. And he's going to be giving us a talk called Medical Ultrasound, What Can We Measure? I think everyone here is in for a treat. I have heard Dr. Rosado-Mendez's lectures before, and they really bring some complex topics and down to what I can even understand. And so I'm hoping that with his knowledge and his ability to explain some of these complex features, it'll be a wonderful foundation for the 3 following topics, which will include discussions on elastography, fat quantification, and advanced flow. Dr. Rosado-Mendez is a co-chair of QMIC, formerly KIBA, which is a quantitative organization that helps to study and validate these emerging techniques. He is part of the Pulse Echo Quantitative Ultrasound Biomarker Committee, which is looking into liver fat quantification quantitatively. I really am excited to hear what Dr. Rosado-Mendez has to say. So Ivan, I turn it over to you. Thank you.
And I'm really honored for the opportunity of opening this session with a broad overview on the different ways we can use medical ultrasound to measure different morphological and physiological and functional properties of tissue. Here are my disclosures. I currently hold research agreements with Siemens Healthineers and GE Healthcare. And as Dr. Fetzer mentioned, I'm actually the co-chair of the Pulse Echo Quantitative Ultrasound Biomarker Committee of the American Institute of Ultrasound in Medicine and the Quantitative Medical Imaging Coalition, the former KIBA. So my goal with this presentation is that after you go through it, you'll leave with some understanding of how we can measure different things with ultrasound. In particular, you will be able to define the concept of quantitative imaging and identify the advantages that ultrasound offers in the development of quantitative imaging techniques. You will also be able to explain in a broad sense the physical and engineering principles behind several quantitative imaging techniques using diagnostic ultrasound. Finally, you'll be able to describe the role that metrology plays in the evaluation of the technical and clinical performance of quantitative imaging techniques as sources of quantitative imaging biomarkers. So let's get started. Measuring is at the essence of quantitative imaging. So let's start by defining what quantitative imaging is. Quantitative imaging is the extraction of quantitative information from medical images, like the ultrasound image of the liver that we're seeing here, for the assessment of the normal state of tissue or the severity and progression of a disease, an injury, or a chronic condition. Now, I want to emphasize this aspect of the quantitative information. This quantitative information ideally will come in the way of a quantitative imaging biomarker. A quantitative imaging biomarker is a characteristic that we can measure from a radiological image, either MRI, CT, and of course ultrasound, in an objective way, and that is evaluated as a surrogate of a normal biological process, a disease, or the way that disease responds to therapy. Why do we want to perform quantitative imaging? Well, quantitative imaging provides valuable information that allows clinicians to target different interventions to the specific characteristics of a disease in every patient. That is, it allows to perform precision medicine. Now, in precision medicine, quantitative imaging is an ideal source of biomarkers that complements those biomarkers that we can acquire from serum or biopsy samples by expanding the information that we obtain from these biopsy and serum samples, providing a comprehensive, especially ample source of information about the tissue without the need to extract tissue, and also allowing for the in vivo longitudinal assessment of the tissue of interest. So by providing quantitative information, quantitative imaging complements the biomarkers that we're used to evaluate in different diseases. Of course, we can perform quantitative imaging with ultrasound because of the safety, practicality, relatively low cost, a relatively small ecological footprint. Ultrasound is well posed to extend the benefits of quantitative imaging to a wider population. This is particularly important if we consider some important trends. For example, it has been more than 50% increase in the number of ultrasound studies from 2010 to 2020. And it's expected that the ultrasound market is going to increase by almost $1 billion in the next 5 years. Moreover, the introduction of handheld scanners and wearable transducers can further enhance access to the novel techniques on quantitative imaging that we're going to cover today. In addition, the increase of computational power opens the door to the development of new technologies that provide information that has not been attainable in the past. But there are physical reasons, and in addition to the practical reasons of why we want to perform quantitative imaging with ultrasound. In my perspective, one of the key aspects of why ultrasound is very useful for performing quantitative imaging is because of its wavelength. For those of you who do not have very fresh year physics courses from the residency, the wavelength is a distance over which the shape of the wave repeats. So for example, let's consider the transducer that we have here, and that transducer is going to emit a tiny pulse that is going to travel through tissue. Here we have it. So if we take a snapshot of that particular pulse, we can see that there will be some sort of rarefaction where the ultrasound wave expands and some sort of compressions when the ultrasound wave compresses the tissue. Now, if we plot that pressure and decompression as a function of distance, we are going to see that we are going to have adjacent peaks or adjacent valleys, and the distance between those valleys or those peaks is what we call the wavelength. So it's a characteristic of the types of deformations that the wave is inducing while the pulse is moving through the tissue. Now, why did I choose to use the wavelength as that specific characteristics that provides an idea of why ultrasound is very important to perform quantitative imaging? To put it in context, let's compare it, for example, to the ranges of frequencies and wavelengths that we can see or obtain from the electromagnetic spectrum, like electromagnetic waves. So here, for example, is the electromagnetic spectrum that expresses the ranges of frequencies and wavelength, going from the visible, infrared, all the way to gamma rays. To put a spatial reference, here this vertical line indicates an approximate ballpark for the size of a cell. Similarly to the electromagnetic wave, we have an acoustic spectrum that also expresses the ranges of wavelengths and frequencies for acoustic waves. It includes, of course, the human hearing range and also the ultrasound range, all those frequencies that are above what we can hear. I'm marking here the range of wavelengths used in imaging, which range from a fraction of a millimeter up to a millimeter. It is because of these specific ranges from a fraction of a millimeter to a millimeter that we can perform several measuring tasks. For example, the use of sub-millimeter or millimeter wavelength in combination to very, very short pulses allows for echolocation, and that allows for the measurement of distances, volumes, and areas. Moreover, because of the variations in the wavelengths with the deformation of tissue or with the motion of tissue, we can detect micron-sized tissue deformation. Finally, by analyzing the wavelength or frequency content of the wave, we can obtain information that is between the microscopic scale that is not possible to see in an ultrasound image to the macroscopic scale, like the size of organs and tissues, allowing us to obtain a link between what we cannot see to what we can see in the ultrasound image. So in the next few slides, I'm going to go through some of these applications. These different applications allow us, for example, to extract quantitative information from the conventional echographic images, like B-mode images and M-mode images, measuring sizes, distances, areas, and volumes. We can also extract information about blood flow. We can quantify the stiffness of tissue. And more recently, scanners allow also to quantify acoustic properties like the attenuation and the scattering properties of tissue. The most basic one that you're familiar to is the use of B-mode images and M-mode images to measure distances and motion. This is made possible by the use of short ultrasound pulses that travel along well-defined directional ultrasound beams, like the picture or animation that I showed in a few slides ago. This allows for a correct spatial localization of echo sources, what we refer to as echolocation. So we can locate the sources of echoes in two dimensions, for example, in the actual location, that is the direction of the propagation of the wave. We can extract the depth by measuring the detection time of the echoes and knowing the speed of sound of tissue. And by knowing the location of the ultrasound beam, we can locate the sources of the echo in the lateral direction. Some of the challenges of the application of echolocation in ultrasound is that it depends on knowing the speed of sound of tissue or assuming a value in the calculation of the depth. Of course, when there are variations in the speed of sound, that can lead to errors in our measurements of distance, area, and volume. And it can also result in misplacement of the sources of echoes in the images. And some of the conventional or more used scenarios of the measurements of distances, areas, and volumes are, of course, in obstetrics when we perform morphological ultrasounds. Now, things become more interesting when we want to detect motion, micromatrix motion. So for this, we need to use the radio frequency echo signals. These signals are the raw signals produced by an ultrasound scanner that carry the information of the frequency or the wavelength that the original wave was sent when transmitted into the tissue. Now, we can take two radio frequency signals at two different times, T1 and T2, and by comparing how the phase or the shape of the wave shifted between T1 and T2, We can, for example, extract information about blood flow, and that's the basis of the different modes of Doppler imaging. But we can also sense motion associated to the compression of tissue. That is a characterization of the stiffness, and that's the basis of the elastography imaging. As examples of these quantitative sources of information, on the top we have a three-mode image of the internal carotid artery. When we have, in addition to B-mode, we have color Doppler and spectral Doppler. On the bottom, we have an example of 2D shear wave elastography that shows a map of the distribution of the shear wave speed, which is a surrogate of tissue stiffness, where blue indicates softer tissues and red indicates stiffest tissue. And in this case, it's an example of the right patellar tendon. Now, if we want to get even more interesting, we can look at the physical mechanisms that define the shape and the frequency content of that radiofrequency echo signal. Now, I won't go into the details of this equation. What is important to know is that this equation carries information about how the ultrasound system is operated, but also about intrinsic properties of tissue, like the attenuation and the scattering properties of tissue. To briefly show you how we can extract some of this information, usually the scanner computes the power spectrum of the echo signals, that is the distribution of the energy of the echo signals as a function of frequency. After some signal processing and mathematical approaches, we can extract a quantitative feature, which is the attenuation coefficient, which is a measurement of the loss of energy as the pulse travels through the tissue due to absorption and scattering. And once we know the attenuation, we can also extract a second quantitative feature, which is the backscatter coefficient, which is a measurement, an absolute measurement of the reflectivity of tissue. Why do I emphasize attenuation and backscatter? Well, because these two phenomena, the attenuation and the backscatter, are behind some of the changes that we see in B-mode images associated with the onset and development of liver steatosis, that is, fat infiltration in the liver. We know that normal livers will have well-defined boundaries between tissue, and the liver will look isoechoic with respect to the kidney. As steatosis progresses, the echogenicity of the liver will increase with respect to that of the kidney due to increased scattering. And the increased attenuation will also cause the loss of definition of and penetration in the B-mode image. So higher attenuation and stronger scattering are behind some of the changes that we see in B-mode images. This has inspired several vendors to introduce the quantification of attenuation and backscatter as potential surrogates or biomarkers for liver steatosis. Here I'm showing two examples of a technique implemented in our lab, evaluating attenuation in a subject with low pearl density fat fraction and relatively higher pearl density fat fraction, in which the attenuation increased from 0.85 to 1.09, and the backscatter in the same two subjects increased from minus 28 to minus 18 decibels with respect to 1 per centimeter per steradian. So I'm not aiming at making any claim on performance of these techniques. These are just examples of the use of attenuation and scattering to monitor liver steatosis. We can further analyze the frequency content of the backscatter coefficient to obtain a plethora of other possible features that provide information about the microstructural characteristics of tissue that are below the resolution limit. Like, for example, possibly the size of scattering sources like fat vesicles in the liver, or the alignment and organization of collagen fibers in the cervical stroma. I won't go into the details of these techniques, but here I leave you with a set of references that get deeper into these techniques. Now, not everything that we quantify in an image is a biomarker, and metrology is at the center of the process of transforming quantitative features to biomarkers. And this is because it provides a framework to understand the sources of error and uncertainty in what we measure. And this is particularly important when we're using quantitative features from radiological images to be used as biomarkers. To transform features into biomarkers, we need to validate their technical performance, that is, assessing the bias and precision or variability of what we're measuring. So if we repeat several times the measurement of the backscatter or attenuation, how similar are those values that we're obtaining? And also the clinical performance. How strong is the correlation between attenuation and backscatter, for example, with liver steatosis? So these two components are part of the process defined by the Quantitative Imaging Biomarkers Alliance to transform quantitative features in biomarkers. As an example of the potential use of metrology to understand sources of uncertainty in the measurement of the steatosis with quantitative ultrasound, there are several aspects that we can evaluate. For example, we can evaluate the sources of error and variability in the algorithm that we use to quantify attenuation and backscatter, going from what are the units that we're reporting the attenuation with, and what are the different processes to extract the attenuation from the radiofrequency echo signals. We can also identify sources of systematic error or bias by understanding possible physical confounders that affect the relationship between the quantitative feature and the biological concept of interest, like the presence of fat, and clinical sources of variability too. For example, how dependent are our measurements on who's operating the ultrasound scanner? What are the effects of hydration, the postprandial state of the patient, among others? So in order to transform our quantitative features into biomarker, it's important to understand all these different sources of error and variability in order to provide a standardized way to quantify the biological concept of interest. So to conclude, some take-home messages. Quantitative imaging refers to the extraction of quantitative features from medical images to use these features as potential biomarkers that can be incorporated in the personalization of patient management. The physical and engineering principles behind quantitative ultrasound can be traced back to the actual physical mechanism that define the interaction of waves with tissue, in particular, those related to the wavelength, the size of the variations of compression caused by the ultrasound wave. Finally, metrology provides a standardized framework for identifying sources of error and uncertainty in anything we measure, including imaging biomarkers. And this is key to transform the things that we're measuring in the images to become biomarkers that are accurate and that correlate strongly with the biological concept of interest. With that, I would like to acknowledge my sources of funding, and I thank you for your attention.
Thank you so much, Yvonne. That was fantastic. I always love your lectures and always learn a lot. For the audience members, a quick question. What has been some of the underpinnings as to why there's so much excitement and opportunity in quantitative ultrasound today, where we didn't really hear about it 10 or 20 years ago? Is there something different about the machines today, or what is your point of view in that area?
That's a great question, Dr. Fetzer. I think one of the key aspects driving the current enthusiasm behind quantitative ultrasound is the actual computational power of the ultrasound scanners. The scanners are becoming more and more able, even handheld transducers, or handheld scanners, which have made possible addressing some of the computational hurdles behind the quantification of these several features like attenuation and backscatter coefficients. For example, to describe the scattering properties of tissue, it is very important to compensate for physical confounders. Like the measurement of echogenicity is affected, of course, by the effects of attenuation and loss. So this computational power allows for the implementation of complex algorithms that compensate for these effects and provide an objective evaluation of echogenicity in an absolute scale.
So what you're saying is, as there's been advancements in MRI and CT, there have been parallel advancements in ultrasound, which allow for a lot of these more contemporary and complex measurements and computations.
Absolutely. And just to provide some background, quantitative ultrasound has been under development for 50 years. One of the key aspects making it possible to be a reality today is the continued effort in developing algorithms that are more precise and more accurate, and that address the different sources of errors that during all this long period have been identified and addressed.
I would like to introduce our next speaker. Thank you, Yvonne. Then our next speaker is Brian Bunnell from University of Rochester. He's here to talk to us about elastography, predominantly with liver stiffness and maybe beyond. So he's going to be talking about shear wave elastography technique, comparing some differences between ultrasound elastography, MR, and a technology called FibroScan, and their use in liver disease assessment, the current evidence, and how to perform these techniques well. We do want to wish a special thanks to Dr. Deb Rubens from University of Rochester, who I've learned a lot from. I'm sure Brian has as well. And so she has guided many of us in her use and discovery in elastography. So Brian, take it away.
All right. Yeah, thank you so much, Dr. Fetzer. It's as you said, my name is Brian Bunnell. I'm an assistant professor of imaging sciences here at the University of Rochester in upstate New York. And it's my pleasure this afternoon to chat with you all about ultrasound elastography, liver stiffness, and beyond. All right. I have no disclosures. So just a little bit about where elastography comes from. So elastography is the measurement of tissue stiffness. And really at its core, the physical exam was maybe the initial form of elastography, a tactile sort of elastography of assessing physically differences in tissue stiffness based on palpation. So whether that's the liver margin in relation to background mesenteric fat or ascites, or evaluating for tissue lesions within glandular tissue, essentially we're just evaluating for differences in stiffness. But obviously, of course, there's a lot of inter-observer variability using those techniques. We need something more quantitative, something more standardized, right? And so that's where the development of quantitative elastography comes into play. That elastography term was first coined in 1991. We have MR elastography available in 1995, and then the first commercially available ultrasound elastography in 2003. So yeah, really we have at least 20 or 30 years of good data on this, on these methods. So just a little bit about how elastography works. Right, we know that the speed through which at which sound waves move through tissue is dependent on the sort of inherent soft tissue or tissue stiffness of the media through which those waves are traveling. You can see some of the representative velocities here, noting that as tissue stiffness increases, our velocity also increases. And so the most sort of common technique of ultrasound elastography is what's called shear wave elastography. And so it turns out that when we apply an acoustic pulse to tissue, as we've seen in the last lecture, that actually results in physical displacement of tissue. And that displacement wave sort of moves throughout through the area that we're studying. And it's that movement or wave of displacement that results in these shear waves, which can be measured by the transducer. And so we can do some algebra to then calculate a representative tissue stiffness value using what's called Young's modulus. And so you can see the formula there, where E is the tissue stiffness. We have a factor of 3. And then that's multiplied by the tissue density, which is sort of assumed or held to be constant. And then C is the speed of those shear waves that are generated by the displacement, and that's what's measured by the transducer. So just a little bit about how we sort of perform this. We ask the patients be fasting for at least 4+ hours. Usually we try to schedule these exams in the morning. And the reason for that is that postprandial portal flow increases the amount of blood in the liver. Increased blood per unit volume increases our tissue stiffness transiently. We use an intercostal window in the right hepatic lobe. We avoid the left hepatic lobe because that's subject to cardiac motion artifact, which results in some sort of natural displacement and relaxation of tissues that we want to avoid, as that can confound our measurements. We measure during a neutral breath hold. This is also a blood flow related phenomenon, whereas changes in intrathoracic pressure can increase or decrease the amount of blood flowing through the liver. And then finally, we want the transducer perpendicular to the liver capsule, as those perpendicular waves result in maximum shear wave generation to give us the most measurable data. As we perform these exams, the first step is to sort of look at what we've acquired and just sort of check for internal consistency, make sure we can rely on what we're seeing. And so we want to measure 2 to 3 centimeters deep to the liver capsule. Anything more superficial than that, we can run into some refractive error as those beams bounce off the liver capsule. Anything deeper than that, we run into some attenuation issues and our signal to noise drops. So we measure 2 to 3 centimeters from the capsule. Most of the available shear wave technology vendors offer, when you get the image, you get this sort of region of interest, and it populates this sort of color map or sort of confidence map showing you the varying degrees of liver stiffness within the region of interest. And so we want to sample within an area that's relatively homogeneous in that area to confirm that we're getting sort of similar tissue. And then finally, we want to avoid any bile ducts, vessels, or lesions. We'll get into a little bit later about maybe where we do want to assess stiffness of lesions, but obviously these elements have different inherent soft tissue stiffness compared to the background liver parenchyma. And so just on this image, you can see here our acoustic waves are coming here. We're moving perpendicular to the liver capsule. We're measuring 2 centimeters and 3 centimeters below the capsule. So this is good technique. So after we get those images, alongside that, we get a data sheet through most vendors that look something like this. And this gives us another area to do some internal quality control. First, we obtain 10 measurements. So you can see at the bottom here, we have 10 measurements. We give the median value in our report as opposed to the arithmetic mean, just to avoid any sort of variability or any particularly high or low values that may sort of confound our data. And then finally, we want to correlate with what's called the IQR over the median, or the interquartile range over the median. And this is just a measure of variability of our measured data points. And we want that to be less than 30%. And so you can see here in this case, we are under 30%. So we know that this data is reliable. So here's an example of where we sort of changed our technique and improved our diagnostic confidence. So this was a hospital inpatient that was having some pain, and as a result was sort of tachypnic and struggling with some of the breath holding requirements for the exam. So you can see on our first image here on the top left, right, we have some areas that really aren't even registering. We have all sorts of colors over the spectrum in our color map. Here in our IQR over median is greater than 50% in this case. So the patient was actually, they got their pain medications. We came back an hour later, same sonographer, same scanner, same patient, same room, same everything. But with their pain under better control, they were able to sort of tolerate the breath holding requirements. And as a result, we've dropped our interquartile range over the median down to 14%. So now we have a more reliable data set. All right, and so just some potential pitfalls to be aware of. Patients with congestive heart failure, again, this is a sort of blood flow mediated effect through the liver. Recent alcohol use, which has an acute inflammatory effect that also sort of transiently increases blood flow. Cholestatic or acute liver injury, again, getting towards some hepatic congestion. And finally, morbid obesity with a lot of soft subcutaneous fat. We run into issues of beam attenuation by the time the sound waves get into the liver. So now that we know a little bit how to acquire these images and make sure that our data is valid, why do we care to measure liver stiffness in particular? And so this is really sort of an epidemic worldwide. It's estimated that 1.5 billion patients suffer from chronic liver disease, right? So this is sort of a lifelong type illness that gives us a chance to sort of monitor where we are on the spectrum of disease and potentially reverse disease as well. Domestically here in the United States, metabolic dysfunction-associated fatty liver disease, or MAFLD, is now sort of the most common cause of chronic liver disease in the United States. And so we know that there's a disease spectrum ranging from simple, sort of benign steatosis in the liver, steatosis associated with inflammation, and it's sort of that chronic prolonged inflammation that progresses to fibrosis and cirrhosis. So that gives us the chance to identify early disease and make some interventions to prevent the moving down that pathway to fibrosis and cirrhosis. And then finally, we know that patients with more advanced liver stiffness and fibrosis predicts rates of decompensation, hospitalization, variceal hemorrhage, development of HCC, and so forth. So if we can catch these patients early on in the disease spectrum, we can hopefully halt or stop the progression of their disease. And so just a little bit about how we stage this. This is based on liver biopsy, which of course remains the gold standard for evaluation of fibrosis, but of course that is not, comes with its own risks. And so that ranges from what we call F0 through F4, with progressively increasing degrees of fibrosis, ultimately resulting in morphologic changes or cirrhosis. And then concomitantly, we see stepwise sort of increase in our estimated liver stiffness via elastography. And so this is this data comes from the Society of Radiologists in Ultrasound, the most recent update. And this is sort of the clinical reference values that we use with shear wave ultrasound elastography. And so you can see that on the left here, the measured stiffness in kilopascals, less than 5 is normal, less than 9, probably normal, but in the presence of maybe elevated LFTs or some other clinical signs, maybe this patient has early inflammation or early fibrosis. So we may need some further testing to evaluate that. From 9 to 13 kilopascals, fibrosis is likely present, though again, we may need, if there's a big overlap sort of in the degree of fibrosis, we may need some additional testing to confirm that. Greater than 13 kilopascals, we do have fibrosis, and then greater than 17, we have clinically significant portal hypertension or cirrhosis. All right, so just a few more examples. Here, again, we have good technique. We're measuring appropriately. Our IQR median is less than 30. Our median liver stiffness is 4 kilopascals, less than 5. This patient is normal. Another case here, you can see already, right, our colors are a little more into the severe range. We have a quality data set, and our median liver stiffness here approaches 16 kilopascals, meaning the fibrosis is present. And this is particularly important in this patient, right? We don't see any sort of morphologic changes, right? The liver margin is smooth. We're not seeing any sort of nodularity or ascites or stigmata portal hypertension, though this patient does have fibrosis. And finally, a slightly more obvious example in this clearly cirrhotic liver, right? Nodular contour, of course, and necrotexture ascites. We have a great data set here, and their median liver stiffness is greater than 20, meaning that they have, unsurprisingly, they have clinically significant portal hypertension. All right, so ultrasound elastography, of course, is not the only non-invasive method by which we can estimate liver stiffness. Another is FibroScan, which you may be familiar with. It's essentially a different type of shear wave elastography that's generally performed in office by our gastroenterology colleagues, where they put a transducer on the right upper quadrant and sort of estimate stiffness, via similar modality. Importantly, though, the FibroScan images often do not contain B-mode images, so we lose some of that internal consistency or internal quality control, as we discussed. But because these are measured essentially, in the same technique, the METAVIR staging and fibrosis staging is strongly concordant between these modalities. The scale is more or less the same. There are some slight differences in the FibroScan vendors, and so they're reported as a range. And so just confirm, as you're seeing those reports, exactly maybe some subtle changes in the scale. Because we don't have the associated B-mode images, the FibroScan, we do get more non-diagnostic examinations. And of course, with our traditional shear wave ultrasound elastography, we get some additional data and can evaluate for additional stigmata of portal hypertension. So just an example from our institution, this was a patient that had sort of chronically elevated LFTs. They went to the gastroenterologist. They got a FibroScan, which said the liver stiffness is 3.7 kilopascals, which correlates with F0 to F1 fibrosis. Right, so probably normal, but maybe some early inflammation again, or early fibrosis. So their provider said, I'm just seeing some other signs. I just think maybe there's a little bit more going on and we're understaging this. So they sent them to us for a more traditional ultrasound elastography. We saw similar findings, median liver stiffness of just over 5, right? So we're just sort of into that cutoff, as you'll remember, less than 5 is normal. So again, we're concordant between our FibroScan and elastography here. Probably normal, but maybe there's something going on early on here that we can catch early. And so they went for liver biopsy, which we see the results up here. They had steatosis throughout the liver, estimated at 35 to 40%, which is up into the sort of moderate and severe range. They did have some associated steatohepatitis, though were without fibrosis at that time. So they were encouraged to make some lifestyle changes. They started a Mediterranean diet and they lost 20 pounds. So they were followed over the next few years. They were still doing okay, but their LFTs remained elevated. And so they saw their gastroenterologist again and said, all right, well, let's see, now that we've made some changes, let's sort of see where we are. So they went for MRI, which showed that they did still have some steatosis. And then they went on for a repeat biopsy, which now shows that we've fairly significantly decreased our degree of steatosis within the liver, now down to 15%. Again, we don't have fibrosis. And then specifically, they comment in the pathology report that there's no portal or lobular inflammation. So we've moved backwards on that spectrum from steatohepatitis back to just benign steatosis. And, so we've sort of halted the progression of disease at this point. All right, so in addition to FibroScan, I think most of us are familiar with MR elastography, another non-invasive method to evaluate liver stiffness. And so just some important differences here. Ultrasound, of course, uses an acoustic pulse. MR elastography uses a mechanical wave with a sort of passive driver on, the patient's right upper quadrant that results in different scales. And so we looked at earlier at Young's modulus. That equation, you recall, had that factor of 3 in front of it. Essentially, that gets divided out using MR elastography. So the scales are different, and as we'll take a look at that in just a second. These do correlate at least moderately with each other, so we know our values are usually more or less in the same range. The MRE does produce more reliable stiffness measurements, and of course also comes with some additional diagnostic information. Though of course MRI is not the right exam for everybody, right? We know that there's a number of contraindications. It's more expensive, it's more time consuming, and it requires certain software and hardware investments that just are not applicable on all scanners or all sites. Whereas ultrasound has no really relative contraindications and can be used in just about anybody. And so as I alluded to, the scale difference, you can see a little bit here. Just make sure you're using the appropriate scale based on the modality you're using, right? Is liver stiffness of 5 on ultrasound, great, that's normal. But 5 on MRI, this patient has either severe fibrosis or cirrhosis. So just be sure you're using the right scale there. All right, so now that we know how to measure that, measure our liver stiffness, how can we sort of apply that in clinical practice? And so as we've seen, we can stage chronic liver disease, we can identify reversible disease and institute some treatment early on before patients are all on the higher end of that spectrum. We can monitor response to antiviral therapy in patients with chronic viral hepatitis, and then I think excitingly, I think we're going to see this as the rates of MAFLD continue to rise, is assessing treatment response to the sort of explosion of the GLP-1 agents and these new thyroid hormone agonists, which sort of modulate the manner in which fat is deposited within the liver. So we'll be able to monitor response to steatosis sort of over time. This is an example from our institution, patient with chronic hepatitis C on a clinical trial. On the left, we have their initial study, which showed a median liver stiffness of just over 10 kilopascals. So, they likely have fibrosis at this point. 6 months later on therapy, we come back and see them again. Their liver stiffness has decreased to around 8 kilopascals, putting them in now the likely normal range. And an additional 6 months after that, we're down an additional 2 kilopascals, 6 kilopascals overall. So again, likely normal. So we've decreased the inflammation and potentially the amount of fibrosis on this clinical trial. All right, and so those are the sort of the clinical implications of evaluating liver stiffness. But of course, we can it's not just the liver that we can use this technology. So we can look at after TIPS, have we offloaded enough hepatic blood supply to see a change in portal hypertension, in the thyroid gland, or in breast tissue, risk stratifying some of those indeterminate nodules. Lymph nodes, similar story, that malignant lymph nodes generally have markedly increased stiffness compared to benign or reactive lymph nodes. So, right, it'd be great to have some sort of cutoff in those cases where the other findings are indeterminate. And then finally, monitoring renal graft parenchymal stiffness as a surrogate for cellular mediated rejection is a similar sort of disease process in the liver, whereas chronic inflammation related to rejection results in progressive fibrosis. So we can monitor that over time and determine if patients need some change in therapy or follow-up. So just one other example from our institution here. This was a patient that came in for scheduled TIPS procedure. You can see cirrhotic liver and ascites. Their median liver stiffness prior to their procedure is greater than 25 kilopascals. We know that they have clinically significant portal hypertension. And then finally, same day after their procedure, we've dramatically decreased their liver stiffness. Now they're under that 17 kilopascal cutoff. So we know that their TIPS is functioning appropriately. It's offloading blood flow through the liver. And so they've responded well to their treatment. And so overall, shear wave elastography is well validated in quantifying liver stiffness and performs comparably to other invasive and non-invasive modalities in identifying and staging chronic liver disease and predicting rates of decompensation. Shear wave elastography is widely available and easy to perform. And finally, there's an evolving role of shear wave elastography in determining when therapy may be appropriate in evaluating treatment response. And then finally, we've seen that there's some promising extrahepatic uses, both in lesion characterization and disease monitoring. All right, so thank you so much for your time and attention, and thank you to the AJR for giving me this opportunity.
Thank you so much, Brian. Fantastic talk, great examples, great anecdotes, and you really touched on many uses of elastography, not just in staging liver disease, but also monitoring response to therapy, whether that's, as you said, placing a TIPS and evaluating the patient's risk of decompensated portal hypertension, or response to therapy after hepatitis C, or some of these other pharmaceuticals that are more targeted toward steatotic liver disease. So fantastic. One question for you is that you were showing what I believe is called a 2D elastography with a little color box, but I've noticed that a lot of companies' elastography tools look a little different. Can you give a little information about how there's a range of different ultrasound elastography implementations, and they're called slightly different on different machines?
Right. So there's, upwards of at least three that immediately come to mind. There's, I think transient elastography or vibratory elastography. And so essentially, right, we're applying different sort of methodologies of how we create our acoustic pulse, or how that sort of manifests throughout whatever tissue we're evaluating. So there are some subtle sort of variations in kind of our expected range of normal outcomes or disease pathology with some of those different methodologies to evaluate liver stiffness. So it's always important just to sort of cross-reference with your vendor and ensure that you're applying the appropriate cutoff values.
Yeah, I know in my experience, a lot of the manufacturers call their implementations slightly different terms, but in general, I've seen that there's a point elastography, which may just be a box and a number without a color, and then 2D elastography, which is a slightly different box and often color-coded. So I think everyone, when they go to learn their specific vendors' implementations of elastography, just be aware that the look and feel and the terminology may be different, but at least within ultrasound and the use of shear wave elastography, the output in meters per second and the kilopascals and the use of the IQR over median as a quality metric is pretty universal across all manufacturers in ultrasound. So
yeah, that's right.
Yeah. Thank you so much, Brian. I think we're gonna move on to one of my friends and colleagues, Teddy Pierce, MD from Mass General Brigham. He's currently a radiologist at both Mass General Hospital and Brigham Williams Hospital, and serves as the service chief of ultrasound for both. Big job. He also leads the clinical arm of a research lab called the Center for Ultrasound Research and Translation. He serves as a SoundSpeed co-chair for PICUS, that same organization that Dr. Rosetta Mendez and I are part of. And he's going to be talking to us about the capabilities and limitations of current and emerging liver fat quantification techniques. We're very excited to hear what Teddy has to say. So Teddy, take it away.
Yeah, thank you for that kind introduction. As you mentioned, I'll be discussing a little bit about ultrasound fat quantification. I hope this talk will be complementary to the two preceding talks. Listed here are my disclosures. So today I'll be talking about three main areas. First, I'll explain the physical underpinning of the sound-tissue interactions that govern the B-mode appearance of the liver, the associated qualitative features, and the limitations of these qualitative analyses. Second, we'll discuss some current commercially available ultrasound fat quantification tools. And last, we'll look to the future. We'll look forward to what the future might hold pertaining to quantitative ultrasound. Metabolic dysfunction-associated steatotic liver disease, or MASLD, formerly known as NAFLD, is among the most prevalent diseases in humans. It's a spectrum of disease that ranges from normal to cirrhosis. Today, we're going to be focusing on simple steatosis with a prevalence of around 30%. This means that worldwide there are about 2 billion people with MASLD. Unfortunately, recent data shows that this incidence continues to increase. Keep this in mind as we talk about various technologies, because implementing any solutions for a problem this big is a big challenge. Now let's turn to the effects of fat on ultrasound. In a normal liver, some of the ultrasound wave is scattered by hepatocytes and returns to the transducer. In steatotic livers, fat deposition leads to increased scatter and therefore increased signal return to the transducer. In a perfect world, this would mean that the liver would be brighter. However, image appearance is governed by a number of other factors which can confound the degree of echogenicity. If you look at the normal and steatotic livers here on the left, the absolute brightness is not substantially different between the two, perhaps because the sonographer has adjusted the gain or some other settings. One way around this problem is to benchmark the liver against another normal structure, in this case, the kidney. When we look at this pair of images, now we can see that the liver is much brighter with respect to the kidney in the steatotic case as compared to the normal case. A second effect is attenuation. The increased scatter that I just mentioned means that less signal is propagated to deeper portions of the liver. Additionally, fat deposition results in increased acoustic energy absorption, which further accentuates this effect. As a result, deeper anatomy suffers from signal starvation in the setting of steatosis. Notice on the bottom image where the deep portion of the liver and the diaphragm can't be resolved due to signal loss or attenuation, compared to the top where we can resolve the entirety of the liver well. Lastly, I mentioned sound speed. Typically, soft tissue sound speed is assumed to be about 1540 meters per second. A normal liver may actually be slightly higher, around 1550 meters per second. But fat has a much slower sound speed, closer to 1450 meters per second. This has important implications for ultrasound beam forming. Normally, the ultrasound beam is focused to improve image quality. However, the success of this focusing operation depends on matching the beam-forming sound speed with the true tissue sound speed. When these are not matched, as in the case with steatosis, the ultrasound beam becomes unfocused, leading to poor lateral resolution, which may manifest as blurring of vessels or the diaphragm, as seen here. The combination of increased backscatter, increased ultrasound attenuation, and sound speed-related blurring are critical to make the qualitative diagnosis of steatosis. But as we all know, this is highly subjective, and it's insensitive for longitudinal monitoring as we try to detect change. The hepatorenal index is a well-described semi-quantitative tool for attempting to quantitate steatosis using available information. It's calculated by dividing the hepatic signal intensity by the renal signal intensity on a B-mode ultrasound image. There are numerous advantages to this metric. It's widely available. It can be calculated on most PAC systems. It doesn't require specialized hardware or software, and there's a lot of literature about it. But there are a couple key limitations that preclude this from being widely deployed in clinical practice and prevent us from relying on it heavily. This technique assumes that the kidney is normal, and in many cases it may not be. It's important to recognize that the echogenicity of the kidney varies based on the incidence of the ultrasound waves because the renal parenchyma is anisotropic. What this means is that if you have slight differences in probe angle or slight differences in region of interest placement in the kidney, you can end up with very different values for the hepatorenal index. This variability is evident throughout the literature when you look at the thresholds that have been proposed to distinguish normal livers from steatotic. That range is enormous, as well as the reported diagnostic performance, which varies considerably across studies. So with this in mind, let's turn our attention to the truly quantitative biomarkers. The first is backscatter coefficient, which is reported in units of 1 over centimeter stradian. This is a frequency-dependent metric, and therefore needs to be adjusted for the frequency of the ultrasound transducer. Currently, pure backscatter coefficient is not commercially available, but there is a related biomarker called attenuation-corrected backscatter, which incorporates information from both attenuation and backscatter. The parameter is reported as a fat fraction or a percentage ranging from 0 to 100% and has been benchmarked against proton density fat fraction calculated by MRI. Initial studies have shown that this fat fraction is able to discriminate between normal and steatotic livers quite well, with an AUC between 0.9 and 0.95. One potential, and I would also mention, has good sensitivity and specificity across all stages of steatosis. One area of potential improvement is measurement precision. One study has estimated that the reproducibility coefficient is 58%. And what that means is that if you acquire measurements today and you acquire measurements tomorrow, 95% of those measurement pairs will differ by less than 58%. But that's a pretty big range. So as shown on the left, there are two examples, just to highlight how this is reported. You can see that there's a large measurement region of interest, and then the estimated fat fractions are reported. In the normal case, it's about 5%, and in the abnormal case here, it's greater than 20%. The next biomarker is the attenuation coefficient. This is the most widely available and best studied of the quantitative biomarkers for fat estimation. It is typically reported in units of decibel per centimeter or decibel per centimeter per megahertz. Like backscatter, it's also frequency dependent. The attenuation coefficient shows moderate to good sensitivity and specificity, and moderately good precision. Some representative images are shown on the left. The color-coded sector is a map of the attenuation coefficient values, and then the quantitative output that's shown in the bottom left of the images is derived from the inset region of interest. These values can be benchmarked against vendor-specific thresholds, an example of which is shown below. There are numerous different vendors that have deployed this technology on their systems, which is great, and it allows it to be implemented into the clinical arena. Although one of the challenges is that the nomenclature differs quite a bit amongst the different vendors. And here's just an example of the different vendors and their naming of their attenuation tool. Another potential challenge of attenuation coefficient is that it may differ between vendors. Shown on the left is a plot of proposed thresholds from individual studies where each dot reflects a different study, and each color reflects a different vendor implementation of attenuation coefficient. Other limitations include that the attenuation coefficient is dependent on the measurement depth. We also need to avoid near-field artifacts. And as of yet, there's no widespread consensus on the optimal technical acquisition criterion, making it somewhat difficult to implement clinically, but also to compare between various vendors. There's a related technology called controlled attenuation parameter. This is calculated during vibration-controlled transient elastography exams, also known as FibroScan, which was mentioned earlier. This technology uses a vibrating probe tip to generate shear waves and sort of a simplified one-dimensional ultrasound to measure both stiffness and beam attenuation. This is widely utilized in hepatology clinics as a point-of-care diagnostic tool. And one of the other main advantages is there's tremendous literature evaluating this in diverse patient populations. The diagnostic accuracy and precision are similar to ultrasound-based attenuation coefficient. And I've shown an example exam to the left, and this is what a typical report out would look like. In the bottom panels are the individual measurements, which we'll look at in a little bit more detail. And at the top are the reported outputs. Shown here is the controlled attenuation parameter, which is the measure of attenuation. And shown here is the tissue stiffness estimate. Looking at a little deeper into the measurement, this three-part panel reflects one individual measurement. On the left here is what's called the TM mode, and this is what's used for guiding the operator to correctly place the transducer. It's essentially an M mode image that we're familiar with. As you can imagine, this may be a little bit challenging to optimize the measurement region placement given the somewhat limited view. And can contribute to misplacement of the device and generating inaccurate values. In the middle panel is a plot of signal intensity versus depth, which is used to calculate the attenuation parameter. And on the right, this is the elastogram, the slope of that dark black band corresponding to the shear wave speed. The last metric is sound speed quantification. Sound speed is reported in units of meters per second. Unlike attenuation and backscatter, this is not frequency dependent. While the quantitative sound speed can be used for tissue characterization, it can also be used for image quality improvement. If we remember back, by correctly matching our beam-forming sound speed with the tissue sound speed, we can improve focusing and improve image quality. An example of this is shown on the left. On the top image, the sound speed is correctly matched to the liver, and the vessels are easily seen and defined, as you can see here. In the bottom image of the same liver taken at the same time, the sound speed that is used to reconstruct the image is incorrectly selected, and it leads to blurring of the vessels. Here's an example of the sound speed estimation tool, where the sound speed is estimated within a region of interest, and the value is reported on the image. As expected, the sound speed is slower in the fatty liver compared to the normal liver, which is shown on the top. However, there are several limitations to the clinical implementation of sound speed estimation. As of yet, there is not a lot of clinical experience with this metric. There are also not well-defined diagnostic thresholds to be able to apply to individual patients. Currently, the measurement is fairly precise with a reproducibility coefficient of 5%. However, it's important to recognize that the entire expected biologic range is only about plus or minus 10%. And so there are still opportunities to improve measurement precision. One other potential confounder is fibrosis. Liver fibrosis tends to increase sound speed. And if you have both fibrosis as well as steatosis within a liver, they may cancel each other out, and you may end up with a normal sound speed, despite having a liver that has both fat and abnormal fibrosis. So why is the environment primed for widespread use of these quantitative ultrasound biomarkers for steatosis? Well, the first is, again, circling back to the scale of the problem. 2 billion patients is enormous. There are insufficient hepatologists in the world and insufficient FibroScan devices to be able to image all of these patients. There aren't enough MRI scanners to provide sufficient access to all these patients. Ultrasound is really the only modality that can serve this entire population at a screening level to be able to detect steatosis. However, current qualitative ultrasound practice is too varied to be reliable when assessing patients because of inter-operator disagreements. There's also the challenge of being able to correctly assess severity, and then a current inability to be able to detect change to therapy. On the other hand, quantitative ultrasound is objective, allowing us to bridge gaps between readers. It's quantitative, which allows us to trend it over time. It's easy to acquire. It only takes 3 to 5 minutes, maybe even less. Compared to elastography, my experience is that it's much easier to be able to train operators to do consistently. As I mentioned, there's the ability to trend over time, and the last is that there is data that supports the overall good diagnostic performance. We deployed this at our institution about 2 years ago, and since then, we've seen consistent increase in volume over time, indicating the unrecognized demand initially, as well as the opportunity for continuing to scale this to help both hepatologists, primary care doctors, and other clinicians. As we move forward, there are several areas that can be optimized. It would be particularly helpful to increase consistency between vendors with alignment of technical acquisition standards and vendor agnostic thresholds to facilitate comparison between different vendor approaches. I also hope that as we move towards this alignment, we will be able to converge on reporting metrics that are more consistent and easier to understand. Personally, I find reporting attenuation in decibels per centimeter per megahertz to be highly technical, very hard to understand, both for expert radiologists, but as well as referring clinicians and patients. I think fat fractions are far more intuitive easier for everyone to understand, and would be an ideal metric to converge our different reporting metrics on. We certainly have opportunities to improve the precision and the accuracy of all of the biomarkers I mentioned. I expect that in the future, we will continue to incorporate the independent predictive power of separate biomarkers and integrate them into single multi-parametric outputs that help us improve both precision and accuracy. This still requires specialized software to be able to implement, which, while available on many systems, does cost money and may not be universally available. There are also numerous parameters under active investigation that I haven't mentioned here that may be incorporated into future quantitative estimates of steatosis. As with many things these day and age, artificial intelligence is also likely to play a role. There is a tremendous amount of data that's captured for a single ultrasound image at the channel level, and there may be artificial intelligence approaches that may be able to more fully leverage that information. The last challenge I think we're particularly likely to see in the near term is how to address discordant cases. This was a nice example shared by one of my colleagues, where the attenuation coefficient value was normal, despite the liver clearly looking fatty on ultrasound, clearly looking fatty on MRI, and clearly looking fatty on a recent CT. And how do we incorporate this discordant information and report? I think this is where we really need to leverage our breadth of knowledge on qualitative interpretation and not become quantitative transcriptionists. I think we need to be able to offer guidance to our colleagues to help them weight the relative importance of the qualitative and quantitative features. So in summary, I hope that I've impressed upon you the need for objective fat quantification biomarkers. Attenuation coefficient and attenuation corrected backscatter coefficient are clinically available and ready to go. Hopefully we can see increasing deployment and accessibility across our ultrasound platforms. I hope that radiologists use these tools to supplement their practice and not replace their practice. There's still tremendous value in our qualitative findings and our ability to critically assess them. Future work would be beneficial in order to align fat quantification practices across vendors and improve the interpretability of some of the quantitative tools that we report. Thank you very much for your attention, and I look forward to answering any questions you might have.
Thank you so much, Teddy, for that comprehensive overview of the current and emerging techniques for liver fat quantification. I know with my residents here at UT Southwestern, they see fatty liver more often than they see a normal liver. And so sometimes they see a normal liver and call it starry sky because they can actually see the vessel walls. So quick question for you. Are you billing for liver fat quantification? And a related question, are you performing liver fat quantification alone, or are you performing it in conjunction with any other ultrasound exams?
Yeah, great question. So we complete all of our exams and code for fat quantification when it's performed. So the billing goes out. I don't think it's frequently reimbursed at this stage, although I expect that will change as utilization increases. We offer the exam as a standalone exam for just fat quantification, which is rarely used. More frequently, we will perform fat quantification along with a limited right upper quadrant ultrasound, or in combination with a limited right upper quadrant ultrasound and elastography, depending on the referring and their preference and what specific question they're looking to answer.
Great. I think that's what we do in our practice as well, and often interpret, as you said, the fat quantification results in the context of what it looks like in the B mode and what the elastography is showing us as far as the stiffness and underlying fibrosis and inflammation. So thank you so much. We'll move now to our final talk of the forum, and I'm very, very excited to introduce Dr. Michelle Robin, professor of radiology at University of Alabama at Birmingham. She's going to cover some Doppler and non-Doppler techniques for measuring blood flow. I think you'll find this talk a real treat. I've always learned so much from Dr. Robin. I look forward to her talk. Take it away.
Thank you, David. I'm very happy to be part of this AJR forum. It's been great so far. We're going to talk about Doppler and non-Doppler measurements of blood flow, and we're going to stray from the liver a little bit. These are my conflicts of interest. And blood flow, as you know, is involved in everything. So first of all, we're going to talk about slow flow imaging, which is has many different vendor names. And so we've chosen to call this microvascular flow imaging, and that's the terminology that we'll use throughout this talk. Then we're going to talk about actual blood flow measurements, both in 2D and 3D. And then we're going to talk about what is coming and is here also, contrast-enhanced ultrasound tissue perfusion quantification. So we had this new toy in 2018, microvascular flow imaging, where we were starting to play with it and determine what it was useful for. And I was on call, had a patient that had a CT 5 days previously with liver mets, unfortunately had pancreatic cancer and gallbladder wall thickening. He also had bile duct dilatation. He had a common bile duct stent, and now it looked like he was septic. And the question is, what is going on? I'm sorry. And on this case, the very experienced sonographer brought this to me and said, you know, the gallbladder wall is very, very thickened and there's pericocystic fluid. But when you look at it, actually, there's no echogenic submucosa here. And so I'm thinking, what is going on? Is this perforated? Let's try our new tool that we have. And so you can see that here we go. You can see that there is discontinuity in the mucosal echogenic area here. I think this is actually perforated, and all this is debris that's just pouring out of the gallbladder. And so we diagnosed this as definitive gallbladder wall necrosis and perforation. And after we accumulated a few more cases, this led to our paper about improved detection of gallbladder wall perforation. But, you know, I disagree now with this term, and we'll talk about that in a minute. We were asked to give this, to write this article, and in this article, we learned a lot. And microvascular flow imaging led us to a discussion of vascularity. And what is vascularity? Vascularity is moving blood in vessels or organs. And the newer techniques that we're using now improve our ability to differentiate slow or stagnant flow from thrombus. So, but how do we assess that? Is it qualitative or quantitative? And how can we do a quantitative measure? Well, to understand that, we have to get back to the basics. So for color Doppler, the phase change from a sound wave reflection off the circulating blood in a vessel or structure shows us moving blood flow. And with that, we can determine whether the direction of flow is away or towards the transducer face. And we can also look at the color saturation, which is displayed based on frequency, based on the speed of moving red blood cells. So we can verify, in case we're not sure, in case things look strange, and our gain setting and everything else looks appropriate, we can verify that the signal is real and not noise with spectral Doppler. Now with power Doppler, that's more sensitive. Although I'll tell you, I almost never use power Doppler anymore. I just use these more sensitive techniques. But power Doppler is a color map of the amplitude of the Doppler shift instead of the phase change. So there's no directional or velocity information with that. It's less angle dependent and it's slower, so motion can interfere. And it also is depth dependent. But we do see smaller vessels displayed. So now, this microvascular flow imaging, there are two kinds of techniques. One's a Doppler and one's a non-Doppler technique. But both of these increase our ability to see small vessels. It further increases our signal to noise, improves our flash and motion suppression, and remove clutter. And here we're talking specifically about Doppler techniques. So it depicts, again, slower flow than power Doppler, which is why I said that we usually don't even use power Doppler anymore. It is angle and depth dependent, and it's slower, so motion can interfere. Now, there are grayscale techniques for microvascular flow imaging as well. And though in those, the decoded pulses that are reflected from the moving red blood cells are differentiating from stationary tissue. So there's no velocity or directional information, which is a critical difference between that and the Doppler techniques. But importantly, there's no blooming, and it also angle independent. It's also limited by depth. So this is a patient with left flank pain, and the clinician thought she might have a stone. She didn't have a stone, and we saw everything really well. You could see with the microvascular flow imaging that you could see more vessels and better. There was some blooming here. There is maybe some blooming here. We put on a higher frequency transducer though, and we can see with microvascular flow imaging lots and lots and lots of small vessels very close to each other, extending all the way to the periphery of this kidney. Now, is there anything wrong with that kidney? I cannot tell, but I can tell you that the vascularity of this kidney, that the parenchyma and the cortex vessels are well seen all the way out to the periphery. So this is the kind of image that you can obtain. This is another patient with left portal vein thrombus, and or is it? And so we went back, and actually we thought maybe there was left portal vein thrombus, but then if you put on microvascular flow image, you see no, there isn't. We're just able to see slower flow with this technique. So one of the purposes of this technique is to avoid suggesting other examinations. We can be one and done. We can figure it out with ultrasound. This is a patient with acute left scrotal pain, obvious torsion here. And normally I still put microvascular flow imaging on because I always want to be 100% sure about it. I think you could say that there's no torsion here, or that there is left testicular torsion here. But I am showing this case to show you the dramatic change. This patient's testicle was detorsed on the table by an ER physician, and this is the microvascular flow imaging after that detorsion. Sometimes you can see things better. The spatial resolution might be a little bit better with the in terms of settings. And in this case, we were doing a parathyroid ultrasound, and we saw an incidental ulcerated plaque. We can see that a little bit better here with this microvascular flow imaging. And this is the prettiest pseudoaneurysm and the slowest pseudoaneurysm that I'll probably ever see. Very teeny little trickle of flow. Looks like stars coming down from that. Don't need to use thrombin in that case. This is an interesting case where microvascular flow imaging was very useful for us. This was a 33-year-old male with pain and mass after heavy lifting at work. And I thought, surely there has got to be a tumor in here. But with color Doppler, we could not see any evidence of a mass that had bled with this traumatic injury. And even on microvascular flow imaging, we couldn't see anything. So I called up the urologist and I said, look, I can't find the tumor. I'd be happy to do a contrast ultrasound study to see if anything in this apparent hematoma lights up that is the tumor. And he said, no, that's okay. I'm going to do an orchiectomy. And I said, well, in case the patient doesn't want to, I can work him in and we can do that contrast study. Well, a couple hours later, I got a call after the urologist saw him and said, the patient doesn't want an orchiectomy. And so please do a contrast ultrasound. And we did not see evidence of a tumor. All we saw was hematoma, no enhancement of this hematoma at all. And here is this patient 2 months later. The mass is smaller. The hematoma is smaller with a little bit of flow around the periphery with microvascular flow imaging. So no tumor. This is another patient, had large ascites, and the clinician thought she must have ovarian cancer. On pelvic ultrasound, her ovaries were normal, but with the abdominal ultrasound, she had retroperitoneal adenopathy, and unfortunately, she also had mesenteric masses. This microvascular flow imaging was very helpful for us to biopsy to see exactly where to go to biopsy vascularized tissue. And unfortunately for this patient, she had mesothelioma. When you use a technique, though, especially a new one, you have to understand the limitations. And one of the limitations of this are the artifacts. So with echogenic foci, you can get artifacts. And in this case, you can see that there is some specular reflection and some reflection off of this calcification. So if you don't see pulsation, then it is very unlikely to be real. This is a patient with testicular lipomatosis, and we didn't see on power Doppler, and we do use it occasionally. We didn't see any flow, but then it looks like there possibly could be some flow in these little echogenic foci, but it's specular reflection. And again, you have to look for evidence of artifact in your images. This is another patient that had thrombus in the left portal vein, and this actually had left portal vein thrombus. Beautifully imaged with color. The color does not, in this case, was set appropriately, so it's not blooming over the thrombus. And but yet, when we put microvascular flow imaging, it did overwrite the thrombus because our gain settings were not correct. So remember, MVFI Doppler can overwrite thrombus, just like color Doppler can overwrite thrombus. So that is an important thing to think about, a limitation of that study. And note that MVFI grayscale will not overwrite thrombus. So you have to know what technique you're using so that you can understand the limitations. This is a case of MVFI grayscale, courtesy of Melanie Caserta. And you can see that there's pretty good flow here, but we can't see real peripheral vessels. The grayscale MVFI shows beautiful vessels all the way to the periphery, and you can see the external iliac artery and vein and the remaining vessels without blooming here very nicely. This is another case that I put in because I had a musculoskeletal radiologist say, I don't use this at all because every time I put it on a lipoma, the lipoma looks hypervascular. Well, that's because your gain is too high. So there is specular reflection off of all these lines, all these linear striations that we see typically in lipoma. And when you set it correctly, you don't see it, nor do you see any increased vascularity in the superficial soft tissues. So you just have to have the settings appropriate, and then you can read it correctly. All right, what's the difference between vascularity and perfusion? Vascularity is moving blood in vessels. That's what we see all the time. And these more sensitive techniques are very, very useful to us. But perfusion is an actual measurement of blood flow, a blood flow rate in mLs per minute. And we're not measuring perfusion when we see flow in a vessel or a structure. So we need to remember that. This is a patient 3 days post-transplant where you can see the vessel upstroke looks great in the mid portion, but in the upper pole, there's a tarsus parvis pattern, and in the lower pole, not shown, there was as well. Well, we noticed this, put power Doppler on, but don't see much flow in the upper or the lower pole, put microvascular flow imaging on, and we see great flow. So I called the transplant surgeon, said, I see great flow in the mid portion, but I don't see very much flow at all in the upper and the lower. And he said, is it good enough? And I said, I can't tell you, because all I'm showing you here is vascularity. I'm not showing you perfusion. I'm not showing you an mLs per minute through this kidney. So that's kind of the holy grail of what we want to figure out. So is microvascular flow imaging perfusion? No. We need additional techniques to measure blood flow in mLs per minute. Now, we have been doing this since the 90s in hemodialysis access with 2D volume flow. I had an R01 where we did it in grafts, and then I was a core director of a multi-center NIH trial where we did it in fistulas, and we used 2D volume flow very extensively to determine flow in the fistula with maturation. And this is a beautiful image. This is a perfect image of how you should measure this. It can be tricky. For more information, I would have you go to this article or some of the other articles to determine exactly how to measure it, because I frequently see this incorrectly measured at lectures. Now, I'm very excited to discuss 3D volume flow measurement, which Doctors Folks and Rubin and Kripkins and Pinner at the University of Michigan are working on. And it uses 3D color flow and power information of a 3D volume acquisition, which is independent of Doppler angle, lumen diameter, flow velocity profile, and angle correction, all of those things which make 2D volume flow very difficult. So this slide is courtesy Stephen Pinter and Brian Folks. And this is a measurement of a fistula. You can see they take multiple axial images through there. And then this is the 3D representation. And this ended up with a decent early blood flow of 212 mLs per minute. And I'm very hopeful that this will continue to evolve. Now, they are doing something else that's very interesting, and they're looking at 3D volume flow acquisition in the umbilical vein, and that is for IUGR, for intrauterine growth retardation, and to follow that during pregnancy. And this is the 3D reconstruction of that. And in this particular patient, the umbilical vein volume flow was 250 cc's per minute. So, what's next? Well, we can do perfusion quantification with contrast-enhanced ultrasound. And with that, we could potentially say, okay, this mass is one kind of tissue versus another based on its wash-in and wash-out curves. We could direct a location to biopsy because we're not going to want to biopsy in a necrotic area. We can use it to direct therapy and evaluate the therapy results. For example, to look after ablation to determine if there's any residual tissue. Then in inflammatory bowel disease, Stephanie Wilson has used it to direct biologic therapy and evaluate the treatment results. And also, we could use decreased CT. We don't need to do CT in these patients, hopefully, and lengthen the interval between MRI. Also, in veno-occlusive disease, I think there's some really interesting potential to improve the ability to diagnose and evaluate the therapy. And these slides are courtesy of David Fetzer, who on the right, you can see this is a very good wash-in, a normal appearing wash-in curve and wash-out curve on the right kidney in a 78-year-old man with chronic kidney disease and hypertension. But on the left, we're looking at the cortex again, and this is a delayed wash-in and not much in the way of washout. Now, note that this is only the cortex in that area. It's not the whole 3D kidney yet. So we're not quite there. And we do fortunately have other tools to use, such as this renal scintigraphy exam to evaluate the anatomy, the uptake, and the excretion. But you can see that we have similar findings in this with regards to the contrast ultrasound that I showed you. So in summary, there's many emerging blood flow applications. I'm very excited about them. I think it's going to tremendously help ultrasound's potential to be the first and the last exam to answer a clinical question. We've talked extensively about slow flow imaging, microvascular flow imaging. We've talked about blood flow measurement using both 2D and 3D. And then the promise and cases of contrast-enhanced ultrasound perfusion quantification. I think all of these are going to continue to develop and decrease the need, again, for further imaging so that we can figure out the answer with ultrasound and stop there. So that's it. Thank you very much for your attention.
Thank you so much, Michelle. It was a fantastic round robin, if you will, the review of all of the vascular techniques afforded to us in ultrasound. A quick question for you. You noticed, you mentioned that you almost never do power Doppler anymore. And so how have your ultrasound protocols changed at your institution in these last few years with these new techniques coming along? And do you encourage the viewers to learn these new techniques and start replacing power Doppler with some of these more sensitive techniques?
Well, we have multiple manufacturers, so it can be a little bit confusing for the sonographers to learn how to do these new techniques with multiple scans, with multiple pieces of equipment. So what I do is I tell them, forget about power Doppler and try microvascular flow imaging on everything or almost everything. Anything that you would put color Doppler on, put microvascular flow imaging. Something else that we did, because these manufacturers all paint them different colors. And so it's hard to know just from the color, if you don't know all of the different settings, is it power? Is it microvascular flow imaging? And so our chief sonographer had a great idea. She said, okay, anytime it's microvascular flow imaging, we're going to color code it blue. So now if it's blue, I know it's microvascular flow imaging. And really, I do tell them, don't bother with power, go right to microvascular flow imaging. And that's helped. I think almost all of us know how to do it by using those things to help people with.
Yeah, I'll say we've done the same thing and standardized as much as possible, the appearance of those slow flow techniques across all of our manufacturers as well, so that we're quickly scrolling through a study, we can identify which technique the sonographers were using for assessment. So we're going to take a few minutes here and open it up to the whole panel. I wish to first thank everybody for the fantastic talks. I definitely learned a lot. I wanted to get some anecdotes. How has quantitative ultrasound changed your practice in the last few years? Teddy, we'll start with you.
Yeah, very. We're definitely seeing an increase in volume of both elastography exams and fat quantification exams. I think many times we're using these in conjunction with other screening ultrasound exams, for example, like in hepatitis B patients, when we're looking for HCC, and we're able to sort of tackle a number of questions all at once, which I think is really helpful. We've seen a big need from our hepatology groups, although, they still rely fairly heavily on FibroScan. But the group that I think has most benefited from this are the primary care clinicians, where they really rely on what we say in the radiology reports to help them triage their patients quickly and accurately. And I think that these tools have made us better as radiologists, as tools to sort of fall back on as tiebreakers if you're not sure about the qualitative findings, or to provide objective measurements that we can trend over time. And we do have a not trivial group of patients who come in every year or every other year for their quantitative ultrasound exam to follow their liver health.
Brian, did you have any thoughts on that? How it's changed your practice there in Rochester?
Yeah. Yes. So the thing that I think most is maybe just building relationships, both with our ordering providers, with our sonographers, working with our vendors to sort of bring this technology sort of across our institution. Right. And then getting by, like Dr. Pierce mentioned, especially from the primary care physicians, we hear from them quite frequently, oh, I didn't even know that ultrasound sonography was an option, and so instead of following these patients with just lab work, over time now we can actually get some quantitative data as a sort of see where they are on the spectrum of liver disease. But yeah, I would say it's building those relationships, interdisciplinary, across with our ordering clinicians.
Yeah. How have you gotten buy-in from various ordering clinician groups? And your methods may be different for our hepatologists versus, say, family practice or OB-GYN, for instance, who often plays a primary care role for female patients.
Yeah. So, I think fun for us to start a conference on some of this, some of this stuff. I think it's message, working within our electronic medical record just to communicate with providers, rather than maybe, I think initially our hepatologist sort of had this reflex to, I'll just send anybody to MRI if I have any questions, and just reminding them, right, ultrasound is capable of doing this at the same level at a much lower cost and much lower rate of complication. So yeah, really, it's having a dialogue with our providers.
Michelle, have you had any successes in how you've engaged and gotten buy-in from some of your clinician groups there?
Yes, for a while, we were the only people in the state doing elastography. And so we got it from everywhere. And while other people still have now started doing it elsewhere, we still do it every day and all day long. And I think it's really, really important. It's exciting. Some patients after treatment, if their elastography scores go down to normal, then our GI colleagues release them to the general population, which is exciting to be able to do that. So yeah, we keep up our information flow, and we're often the first people that the patients come to before they even go see the GI. They say, okay, you need an ultrasound first. So
Ivana, a question for you. With all these techniques that are emerging and all of the fantastic underpinning science and physics of these techniques, where do you see quantitative ultrasound going in the next few years or decades?
It's a very interesting question. I think because of the increasing understanding in the relationship between what we're quantifying and the underlying pathology and biological changes at a microscopic level, I think we will start realizing that a single quantitative feature does not describe the complexity of a disease. So we are going to start building multi-biomarker assays based on quantitative ultrasound, and of course, incorporating other demographic and serum and biopsy-based information. And I think that would be the only way that we could actually really address the different facets that the development of a disease can have at a personalized level.
Yeah, hopefully AI can step in. That's a lot of data points to keep track of for a busy radiologist. And going along that theme, Teddy, so, we've all kind of talked about how some of these quantitative techniques require some context, but for a busy radiologist in a very busy practice trying to roll out a quantitative technique, how do you manage the quality of these techniques, and how do you interpret them without the context of all of the clinical information, especially if you're just seeing the elastography, the patient's already left and you don't have access to their lab values and the risk factors?
Yeah, that's a great question. So, for elastography, I found it to be at times somewhat technically challenging to uniformly practice. I think adopting 2D elastography has been really helpful because you can, as a radiologist, get a qualitative sense of how well the measurement has been performed. With point, it just, you don't have any additional information. It's just sort of a number. I think we've worked really hard with our sonographer group to try and streamline the image acquisition instructions, because there's a lot of things that they have to juggle in their head when they go to acquire these measurements. Related to breath hold timing, transducer positioning, angulation, measurement placement. And so trying to streamline that both with the instructions and hopefully, in the near future, having automated region of interest placement algorithms on vendor systems. I think things like that are quite helpful. We've conducted some rigorous QI projects that have helped us reduce our non-diagnostic rate fairly substantially. I think for the outpatient setting, interpreting the elastography exams hasn't been terribly challenging. I think the place where we run into a lot of difficulty is with our inpatients, where there's a lot of confounders of stiffness, which may make the values not necessarily reflect fibrosis. And both in the positive and negative way. A lot of times you can overestimate it, but you can also underestimate it if people are aggressively diuresed. And essentially every inpatient we have has confounders. And so I think that's where it's been really challenging. The fat quantification, I haven't perceived the same level of complexity, but I also worry that maybe because maybe I just know less and we know less about what the issues of it are. And so I think these will be things that I think we will learn more about as we use it more and can study it more down the road to understand, what we're missing and what gaps are still left to fill.
We also have a pretty robust training program too, so that we have our sonographers do 10 patients first that look like they're good and all the parameters are appropriate, grayscale and the measurements. And so then once they've gone through that training, then they can start acquiring these images independently. And that helps a lot.
Yeah, I agree. Having a really clear protocol and a good QA program is critical for many of these quantitative techniques.
Mm-hmm.
So I think it's time to wrap it up. I really appreciate everyone's time. All 4 talks were fantastic. I learned so much. And I know each and every one of you is involved in the research of these various techniques. So Teddy, those confounders and additional investigations, I'm sure will come out of this group, and we'll start to learn more about these techniques and all the emerging techniques that Yvonne was teasing us about. So I wish to thank all the audience members for their time and attention. Really appreciate AJR for this opportunity for us to share these exciting talks with you. So with that, I'll conclude and thank you again.